Ladies and gentlemen, welcome to the Beautifully Broken podcast. I am here with Joshua Routh. Dr. Routh, how are you doing today?
I'm good. Thanks, Freddie. How are you?
I'm excellent. Excellent morning. You know, I had a night's sleep where I had I don't know if you ever woken up in the middle of the night, and it's not like you can't sleep, but I'm filled with ideas, and my brain is planning to, make this incredible impact in the world. And I was just so excited about life, I couldn't sleep. But I did my morning routine and I got to the gym, and I honestly, I feel really good. I'm really excited to have this conversation.
Wonderful.
Yeah. How did you sleep, by the way?
I slept pretty good. Yeah. I've got a couple of kids. I've got a 5-year-old and a 7-year-old. And so if I ever have trouble sleeping, I can just go in there and snuggle those guys. So always delightful. Fun times waking up with them. Totally different energy in the house than before kids, for sure.
Amazing. So we met at A4M, Advancements in Medicine and Longevity in Las Vegas this past December. And your team had a really unique test that lots of people are talking about across the space of oncology and cancer and early detection, known as EpiSeq. And that is the test, correct?
That's right. EpiSeq. Mm-hmm.
EpiSeq. So, this has been in my field of awareness for a long time. We've not talked about it on the podcast. My understanding is this test is some sort of a liquid biopsy solution for early cancer detection. So I would love to jump in. And am I getting that right? Am I describing the test and in fact how it works and how it functions? I'd love to break that apart with you for the audience.
Yeah, absolutely. So you said a lot of the right words there. So it's a multi-cancer early detection test. It's a liquid biopsy. This kind of testing is really something that a lot of healthcare providers have been asking for, patients have been asking for. One thing we know about cancer is the later you diagnose it, the worse the outcomes for patients. And we have some really phenomenal testing for some cancers where we can detect them early. Colonoscopy is maybe the poster child, right? Where you can find that colon cancer before it's even technically cancer, treat that, get rid of it. The problem is there's so many cancers and there isn't a great test for many of them. So these cancers aren't detected until later when the patient's symptomatic. What EpiSeq does is it looks at the patient's blood, looks at some epigenetic markers in there. So not actual DNA sequencing changes, but changes in part of the system that regulates gene expression, and determines, do we think that this patient has cancer or not? And it really is effective at looking at a lot of cancers and many cancers that we don't have effective screening for.
Incredible. And I would love to understand, both for myself and maybe the home listener that does not have an in-depth medical background, how would we describe, how is this functioning? How does it really work?
Yeah. So how does the test work? What biologically?
Yeah. Walk us through, I'm sitting with my practitioner. I said, hey, Freddie, you expressed interest in doing a liquid biopsy blood test for early cancer detection. I've got a box in front of me that I've ordered from you. What happens next?
Yeah. So the thing that we're looking for is something happening inside your body. So all of your cells are connected to your blood supply, right? That's how they get oxygen. That's how they get energy. Some of those cells change and start turning into cancer, right? They're still connected to that blood supply. When cells become cancer, when they start developing cancer, they multiply more than other cells. That's one of the hallmarks of cancer, is this kind of out of control growth. And as those cells are growing, some of them die. And when they die, some of their DNA goes into the bloodstream. So EpiSeq, what we're doing is taking a blood sample, so just a couple tubes of blood in your doctor's office at a phlebotomist, in some special tubes that stabilize that DNA. They get sent to us in the laboratory. We do our analysis on it, and we're able to kind of separate, do we think that this patient has cancer, or we don't see evidence of cancer from this. And it's really looking at that cancer DNA that's there in the blood sample.
If we were in a lab, what would the lab technician be doing? I know I've had guests on, they've done advanced cell spectrometry.
Mhm.
Sometimes people are counting cells under a microscope. What are you guys looking at in the biopsy?
Yeah, those are all great techniques. We don't look at the cells. So what we do is we take the cells, we get rid of them. So we spin the tube really fast, create some artificial gravity to get the cells at, and we're left with a cell-free component. That's called plasma. We take that plasma and we do some chemistry on it that grabs onto DNA and lets everything else go away. And that's DNA isolation or nucleic acid isolation. So now we're left with DNA. Some of it could just be normal DNA. So regular cells in your body are dividing, multiplying, and dying, and some of that DNA gets left in there. So just the fact that there's DNA doesn't mean that there's cancer. We've got to do some more testing to determine, is this DNA coming from cancer or from healthy cells? And what we do in the laboratory is a chemistry called bisulfite conversion. It's a chemical process that changes DNA based on whether or not it's methylated. And then we have some techniques that are similar to PCR that everyone's familiar with from COVID testing, where we amplify, we make extra copies of DNA that looks like it's coming from cancer. We're able to detect that then. We've got some computer software that analyzes that. We use some machine learning to help develop that, and then make a determination of, hey, do we think this is cancer or not?
Okay. So PCR is polymer chain reaction for anybody. Is
Polymerase
that
chain
correct?
reaction. Polymerase chain reaction. Yeah,
Polymerase chain reaction.
there you
And
go.
then
Yeah.
we talked about methylation pathways. Could you explain, because sometimes we'll say a term and there's an assumption that everybody knows what we're talking about. Now,
Yeah.
I have a supplement in my cabinet that is methylation support from Thorne because I want help methylating. I've looked at my genetics and it says, Freddie, you might want this in your longevity stack. Can
Mm.
you describe to us the process of methylation and why it's important?
Absolutely. So you've got different cells in your body that do different jobs, right? But you only have one genome. So the genome, the DNA, you got one copy of your genes from mom, one from dad. That's kind of a fixed, static thing. And it's the instructions for all of the protein machinery in your body, all the enzymes in your whole body. But a neuron doesn't need the same machinery that a skin cell needs, right? They've got very different jobs, but they have the same blueprints. Epigenetics is the study of how does the body turn genes on and off in a healthy way, and how are genes turned on and off in disease as well. So aging is likely a methylation-related disease. That's why those supplements make sense scientifically. And then cancer is also a methylation epigenetic-based disease. So cancer, you get genetic changes, but also that same methylation framework that changes gene expression in a healthy way in different parts of your body. It can use some of the machinery that normally isn't used by a cell. It can turn genes on, turn genes off in a way that changes the behavior of those cells and helps them develop cancer. Methylation is one of those mechanisms. Methyl is a little carbon that can get attached to a DNA. In humans, we talk about 5 cytomethylation. So cytosine becomes methylated at a specific site there. And usually what happens is that methyl group is added in a part of the gene that doesn't get turned into protein, but it's important for the expression of that. So do we want the machinery to lay down there and turn that gene into functional protein or not? And so it's just flipping switches on and off that allows the cancer cell to use some of the machinery that's useful and helpful otherwise, right? But in this context of cancer is dangerous.
Yeah. So what's happening in the body? Essentially, we're getting this abnormal methylation pathway.
Yeah. So it's an abnormal, right? So the methylation that is normally there and healthy, right, is changing, and so we're getting activation of genes that may normally be associated with growth and repair, which is a good thing, right? Growth, but out of control growth is bad, and cancer has out of control growth, right? And so some of the same methylation things that can be useful during that healing process, healing is done, and now it's causing disease.
Yeah.
Yeah,
I want to just step off the trail for a second and just,
sure.
what's always amazed me about the human body is we talk about the genes and how many, we have a blueprint for cells. And then
Mhm.
there's so many more protein expressions than we have like the blueprint for. That has always been one thing that I'm like, it's hard to imagine a system that's more intelligent than the human body, right?
Yeah,
It's just got to do all these incredible things from this small amount of how many protein expressions are there? Like 140,000? It's a
we
lot.
we have about 20,000 genes total, right? So that's
Yeah.
coding things, but those can be recombined and modified in different ways. So we call them isoforms, where in one biological context, the gene will do one thing, and in another context, it'll be cut up differently, twisted around differently, and do something else. So you're absolutely right. It's like it's almost like a compression algorithm, right? Where you've got all this data, and then it's been compressed down into this tiny footprint. It is beautiful, absolutely.
Yeah, it really is. I mean, if you ever wanted proof of like a higher power, it's like wild. And it's math. That's the other thing. There's like math involved in all this.
Mhm.
Um, coming back to I'm in the room, right? I'm in with my doctor. I've got the
Yeah.
box. I understand the test. What and I've got my blood draw, right? It goes away. How long does that take to come back average normal?
Average. So our goal is to get it back to you in a week, and we do that over 90% of the time. We get those results back in a week. Yeah.
Okay. And what am I getting when I come back to the test? What am I going to be looking at?
So yeah, what comes back to you is a report. So we generate a lot of data, look at a lot of data, have algorithms do it. We talk to patients, we talk to doctors. You probably don't want all that data. You want the answer. Do we think that there's cancer, or do we not think that there's cancer? Right? Those are the things. So we've really boiled down the report to either saying cancer signal not detected, so we're not seeing in this blood what we would associate with cancer, or we're seeing an abnormal methylation signature. And then there's a lot of language that we've kind of developed to help explain to the doctor, to the patient, what's there. One thing I feel like we should note is this is kind of new testing. So most doctors order colonoscopies, order mammograms on their patients, perform pap smears. They know what to do with those results. But this is cutting edge stuff, and a lot of doctors aren't super comfortable, don't know what the next steps are. So during this period, it's really important for us as a laboratory to support those professionals. So anytime we have a positive result, I'm on the phone. So I'm the laboratory director, medical director of the laboratory. I'm responsible to make sure that the follow-up is appropriate there. So I'm on the phone with the ordering doctor, talking to them, and oftentimes talk to the patient as well. So we really do want to make sure people understand what the next steps are, what happens after a positive result happens.
Yeah. I have so many questions. So let me ask you this.
Yeah.
Uh, if somebody, let's say someone, well, let me pre-question. If 100 people run this test, and maybe you've seen the scope of tests come in over time, or that this technology has been developed for a little while. If 100 people take the test, how many people come up with an abnormal methylation pathway or abnormal results?
So let's up the numbers because most people don't have cancer. So let's say 1,000 people order the
Okay,
test,
a
right?
thousand.
1,000 people. Most of those people do not have cancer currently, right? We think it's somewhere between 0.5% and 1% would have cancer, right? There's also, anytime you have a laboratory test, the possibility of false positives and false negatives are there, right? So you've got a sensitivity, specificity. We really strive to not tell people that they might have cancer if they don't have cancer, right? So we try to set the marker for that is something called specificity. It's how likely is a positive result to be positive kind of situation. So in those 1,000 patients, maybe 5 of them would have positive results, and they end up having a cancer. And then 5 patients in that group would have a positive result also, but in the workup for it, we can't find a cancer. So there's no cancer cause. There's something else causing that methylation signature there. So 50-50 doesn't sound great, right? For a positive predictive value, that doesn't sound stellar, but that is the cost for being able to detect these cancers early, right? If we made it
Yes.
so we were 100% certain, we'd only be able to pick up the really late stage cancers, and we wouldn't be able to change health outcomes. So that's part of the kind of calculus of designing the test there.
Yeah. Who would you recommend to get the test? Like if
So
you had a magic wand and you could say,
absolutely,
who's this right for?
yeah. If I could, if I was in charge of making decisions for the whole healthcare system, um, the the test is more beneficial if you're more likely to have cancer, right? And so the older you get, the more likely cancer it just becomes more and more likely over time. So one way to do recommendations for cancer screening is looking at the age and then some of those statistics, positive, negative predictive value in that setting. So certainly patients 50 and above will benefit. Cancer really starts ticking up there. I would start getting the test when I was 40 because I think that the benefits outweigh the costs at that point. But people can make their own decisions, and we've had people in their 20s get the test. We've had people in their 30s get the test as well. Cancer can happen before the age of 40, certainly, right? There's no cutoff that says it happens only at these certain ages. So it's really going to depend on kind of your own personal desire to know kind of things there. The other group I think really it makes sense to do are people that have a family history of cancer that's abnormal. Maybe they know that they are a carrier for a mutation that increases the risk of cancer. If they have some other risk factors for cancer, from maybe a work exposure or something like that. So just based again on kind of assessing that personal risk and determining, does this make sense or not?
Yeah. Yeah. I mean, in my head, I'm like, over 50,
Yeah,
smoking, excessive alcohol consumption, lack of mobility, obesity, family history, a genetic predisposition like Lynch syndrome, that
absolutely.
would be a good portion of the population who'd say, look, check the box. And again, I think it comes back to the point you made. This test, it's not about a 100% accuracy. It's about early detection. So using the tools that we have in the toolbox today, for me, I'm saying this all, and I was like, oh my goodness, what a personal choice this is. Because I'm guarantee you there are people that are like, I don't want to know that.
Absolutely. Yeah. Yeah. I was talking to my dad the other day. He's in the age group that I think would benefit from this. He'd prefer
Yeah.
not to. He doesn't want that information. I, to me, we can do something about it, right? Like if we can make a change and do something about it, I'd like to know. There are certainly, genetic things that we can't do anything about, or I'd prefer not to know, right? There are some genetic disorders.
Hmm.
I had a ApoE4, and my risk of Alzheimer's disease was greatly increased. I'm not sure I'd like to know that information, right? Because I don't
Mm-hmm.
know if there's anything we can do about it. I probably would like to know because we're learning things, right? And I could be on the lookout, make some lifestyle changes. But I definitely understand people not wanting that information. And then if
Yeah.
you're the type of person where, a false positive, which is a possibility here, if that would cause you, personally undue stress about this, then I think you can make the personal decision and say, this wouldn't be worth it to me for a
Mm-hmm.
50-50 in that period. Because it is very upsetting for people to find out that they may have cancer. That is not something that anyone would like to hear. Yeah.
It is, but I will tell anybody that hears this on this podcast, anybody you listen to this, that's upsetting. I promise you, it is way more upsetting to wander into an emergency room and say, Freddie, not only do you have cancer, but you have 9 tumors that had spread throughout your abdomen, surrounding your kidney, the vena cava of your heart. It's so different. I
Mm-hmm.
know it's scary. And there's so many people out there with these stories of just, going through late stage disease that the odds were severely stacked against them. We've had Casey West on the show. He's a Marine who has had stage 4 glioblastoma. He's 3 years out, right? He's defying the odds. And it was a situation where he had wandered in dizzy with headaches. We're talking there was a progression. So I would just tell everybody that, yes, it's scary. And I also think, dig deep in your soul and see if you have the courage to meet your body where it's at. Because I promise you that stage 1 is way less severe. And we just did a podcast yesterday on testicular cancer and a male who had it once. It was just a small primary tumor. And then, 13 years later, a recurrence in the abdomen, retroperitoneal lymph node dissection, severe recovery and repercussions of that surgery. So it's I don't know. I'm so excited, man. I would have loved to have this information, but it'd be tough to swallow it as 26-year-old to be like, are you kidding? It's not going to happen to me. I'm Superman. And that's exactly why I waited so long to go seek any kind of help. Yeah.
Yeah, definitely. Yeah, I think that for me, the case is clear that this is beneficial, right? This is why I'm working on this, why I'm in this field. I think we can really help people. We can change the face of cancer in a lot of ways here and prevent just unnecessary suffering, unnecessary death in the field. But as a physician, patient autonomy to me is still paramount, right? And so that's why, if you've got to make this decision for yourself, you and your doctor together is always, I think, sound advice. Yeah.
I love that energy, Josh, and I respect that it's not, you're not pushing this. You're like, here, look, here's an option. Here's the science. Here's what this tool does. Here's what we can find. Here's the possible benefit. But I really do respect that, because I think it is a highly delicate situation, and everybody's going to have a different take on this given the relationship with their body and the medical system and their doctor. And, I could go on and on. Can we talk about, so I actually heard about the test. I was probably listening to a podcast. With Tony Robbins. He was talking about he's like, oh my God, the face of medicine is going to change. We're going to do, something with this test. We're going to be able to do all these things, and you're never going to have late stage cancer again. And I've not done the test. I've not done the test. I've actually asked for it and just never went through with get in the box and draw on the blood, and I've waited because I think I do labs 4 times a year. If I feel anything, I go get a scan. I check the protein markers, the alpha BCHG, alpha fetoprotein, luteinizing hormone that were associated with my cancers. Yeah. Whenever I have a concern, that's so I do a lot of stuff, and then the lifestyle stuff. So I feel good, and I just waited. And then I would love to know, because there's a couple tests on the market. Are they doing exactly the same thing? Are there different levels of efficacy? Can we talk about that a little bit?
Yeah, absolutely. So there is one test that is kind of the market leader here, and I'm not going to mention it by name, but you can probably figure it out. And it's very similar to EpiSeq. So there's a lot of things that are similar. I want to say I think it's a fantastic test. I know people that work for this company. I think they're doing great work. And it really was a leader, right, in raising awareness in this field and cutting edge in the development of some of the things here. So there's a test that's out there that is also looking at cell-free DNA methylation signatures. It's using a different, instead of using PCR polymerase chain reaction, the way that EpiSeq uses, it's using sequencing, which I've run medical sequencing labs. Most of my career has been doing that work. And it's a fantastic technology because you can look at you can look at basically more information at the same time. But it's a more finicky technology. The stars kind of have to align for you to look at pieces of DNA. And a lot of the time with cell-free DNA, your body actually fights against cell-free DNA. So viruses have DNA, and your body doesn't like viruses. So as soon as that DNA is out there in your bloodstream, your body's trying to take care of it because it could be a virus. It really tell the difference. And so this DNA is often in really small pieces and it's damaged. Sequencing can have a difficult time with that because it needs everything to be perfect. It needs the chemical to be correct on both ends, to adapt some things on there. So there's a lot of things that can go wrong. PCR, on the other hand, can work with damaged things. You can have abasic sites. It's a more robust look, but we can only look at a handful of targets. So what we did is we're using this technology that maybe can look at more molecules of DNA, can detect a lower amount of DNA, but a limited number of markers. The other test is looking at a huge number of markers, but it's only getting the really pristine pieces of DNA. So that's kind of a 50,000 foot view of the difference. The advantage of PCR here is in early stage cancer, the amount of DNA that's out there could be very low. So we're talking about nanograms, 0.1 nanograms, really tiny amounts. So in that tube of blood that you get drawn, right, there could only be a handful of molecules. And if we lose those molecules because they've been damaged or something and we're not able to detect them, then that's going to come back as negative, right? And so it's this needle in a haystack look. And that's kind of one of the main technical differences between the two. And so we have some data that's out there. We have published data. We're continuing to do clinical studies. Those early cancers where I feel like we can have the most impact, I think that's where PCR has some advantage for sure in being able to detect those really low levels of DNA.
Yeah. And remind me, what's the price point right now of EpiSeq?
EpiSeq right now, I believe the list price is $700, so $699.
Okay.
The price point.
$699.
Yeah. Mm-hmm.
Great. And I think I from memory serves, it's been a while. The other test is like $1,000.
That's ballpark. Yeah, I think that.
Ballparky. Do you guys have what is your vision for EpiSeq? Is there a price you want to get it to? Is there like two-part thing. Is there a price you want to get it to? Is there a you don't have to answer that, but is this something insurance covers?
So I'll answer the second question first. So currently, no. Insurance does not cover any multi-cancer early detection test. A lot of the work that I do with this company and other laboratories is helping make the case to get insurance companies to cover a test. I think it's only a matter of time before insurance does cover it. The data is strong, right? The case, if you talk to a human and you explain we can detect cancer earlier, they need to protect the money that is coming in as premiums, right? You don't want to spend that on things that have no scientific or medical merit, obviously, right? But I think there's a good case for this to happen. I think we're probably a few years away still from getting insurance coverage.
Okay.
In that, I can't speak to a specific price point for EpiSeq, but one of the advantages of this technology and what we're driving towards now is really reducing the cost and complexity. So next generation sequencing, that other technology platform, the equipment costs millions of dollars for the laboratory, right? This test, EpiSeq, really, this is equipment that was broadly used during the COVID epidemic, right? And so we've got a lot of more accessible technology there. I think one of our missions is to make cost-effective testing that anybody could afford, right? Even if insurance wasn't going to cover it. I don't know if we've achieved that yet with the $700 price point. I think we're continuing to make improvements to the process, to the technology, to try to get that price down. Yeah.
Yeah. I mean, I'll just say from my experience, $18,000, $19,000 a week for just the one chemo infusion per week. She's expensive. It's an expensive journey. So it's, again, I want to pivot to, let's say I am, one of the 5 out of the 1,000 and I get back abnormal results. What do I do?
Yeah. So it's really going to be kind of you and your doctor together at that point, figuring out what the next steps are. So in just anecdotally here, not sharing personal details, but in the cases that we've
Mm-hmm.
had positives, the majority of them, I've talked to the doctor, we've kind of reviewed what's going on with the patient, and there's something there, right? So it wasn't a completely asymptomatic patient. They had a concern, right? And so the first thing, history and physical, I teach at a medical school as well, right? This is the supreme diagnostic tool, is talking to your patient and finding out what's going on in their body, right? And so if we're able to direct next steps by what's going on in that patient, if they have, actually I noticed a breast lump, right? That was one of the cases, was after the result came back, we worked that up. That was the answer. That was the diagnosis, right?
Mm-hmm.
Another one, oh yeah, I do have this other lump here. So if there's anything we can use from history or risk factors for certain cancers, we can explore those things. In the majority of cases, the next step is imaging to determine what's going on. So we recommend currently a PET CT scan as a follow-up. This is the CT part of it is looking at kind of the structural image of the body. The PET part is a positron emission tomography. That's looking at where is sugar being used abnormally in the body. One of the interesting things about cancer is it uses sugar differently than the rest of the body. So where are we using sugar abnormally? And so you've got kind of imaging findings. You've got this biology, this methylation that's there, and then next steps are directed from that point.
Yeah. Yeah. Fascinating. I'm always, oh God, who was it? I was watching a documentary on Otto Warburg, who was looking at the changes in a cell. Otto Warburg, changes in a cell and its voltage, or how it was functioning, how it was breathing, what it was using for fuel. And this is I wish I had a date in the middle of my head when this discovery was made. The 20s, was it 1923? It's been a while since we understood this mechanism that cancer is definitely a component of the fuel for a cancerous cell or a tumor.
Yeah. And you cut out for a second there. Are you talking about Milberg?
No, Otto Warburg.
Otto Warburg. Yeah. Okay. Yes. Yeah. So this is, I think you're right. This is like 100-year-old science. Still very fascinating, still useful information, right? Where
Yeah.
the cancer is switching to a different energy metabolism system, certainly. Still something we're targeting drugs toward, something we're exploring to see, can we look for that as far as a diagnostic tool and a blood-based test as well. Definitely interesting stuff there that I think is underappreciated. And it is old science, right? This is an old study. Yeah.
Yeah, even the chart, like how I forgot how they were doing the measurement, but it was measured in a healthy cell had a transmembrane potential. It held a voltage, a millivoltage, from the outside of the cell to the inside, and that dropped dramatically when a cell became cancerous. And it was actually, I'd remembered seeing somewhere there was a chart where it was a healthy cell to it's doing okay, to a chronically ill cell to cancer, and there was a progression in that millivoltage drop. And it's an energetic thing as much as it's a physical thing. So take that how you will on the podcast, but just fascinating reading and definitely somebody to look into. What are your thoughts on where we're at? Let's focus on the US. I think there's a lot of, anyways, within my field, within my little silo, my area of bias, there's a lot of dissatisfaction with healthcare, if we'll say that. The joke is that it's just disease management and that's, if we look at it, we do manage a lot of illness. We don't necessarily, there's not a lot of cure. I've always been such a big believer in the environment, or the epigenome of my life choices are impacting health. Like, how do you think the war on cancer is going in America, and how much would you like to see of that conversation around the epigenome of somebody's lifestyle be brought into play in the world of oncology?
Yeah, no, that's I think a great criticism. Certainly, we focus on disease and disease management and not on optimizing health. That's what our medical system has kind of traditionally been built around. And that's what, the financial structure is also built around, is how complicated is this patient based on diseases? What do we do based on complaints, diseases, instead of how do we optimize this patient's health? And even when you talk to specialists, right, the more specialized somebody gets, the more laser focused they are on kind of the organ system and the things that are there, right? And I don't think anyone's doing it maliciously, right? You're spending the bulk of your time with very ill people, and it changes your perspective on what your role is. There's so much momentum for you to behave that way. The doctors that kind of break out of the mold and go into functional medicine and wellness, I'm very interested in that, because it is so different. The evidence you evaluate is different. It's a very different situation. I'm a pathologist. Pathology is the study of disease, so I'm the most disease-specific type of person that there is.
Yeah.
But as a patient, I recognize, I go see a neurologist, and they're not interested in my life. They're interested in this extremely narrow portion of my life that, that's what they want to talk about. And if I've got other things, they may not be open to it. So I feel like I went off topic a little bit there.
No, listen, it's great. Yeah.
In oncology, I think we've made some phenomenal progress, right? There are cancers. Once you're diagnosed with cancer, we've optimized how do we study that? How do we figure out which treatments work the best? How do we compare treatment algorithms? How do we integrate genetics in to find out that the treatment that's going to work for you, not for everyone? Oncology is the part where precision medicine, which is that field of kind of tailoring medical care to a specific person, not to just a disease in general, that's where we've made the most progress in medicine overall. But I do think we still have a ways to go in that. In medical school, we talk about something called the biopsychosocial model, where the biology part of it, right, that's where we're focusing on disease and specific cellular mechanisms, et cetera, right? That's only one component of caring for a patient. The patient's psychology, how they're dealing with it, how you're presenting information to them, that is as important for kind of their experience in the disease as if you're picking the right medicine to give to them, right? It can be a very different situation there. And then the social kind of framework as well. I think obesity is a great example where, we're developing new drugs to help fight obesity, but what are we doing to help as a society fight against the obesity epidemic, right? What are we doing for psychology and some of the things that are contributing to obesity there, right? Where, again, we can get reimbursed for a medicine, and so there's money and resources going to that, but it's only one component of the whole problem, if that makes sense.
Yeah. Yeah, I think, we've touched on it a couple of times. It sounds to me like it's shifting that incentive model over time. So while we wait for that is people. I always remind, you do not need legislation to change so many of the big needle movers today. Totally. You don't need legislation. You don't need a bill. You don't need a permission slip. You don't need someone to tell you. It's really like tapping in and saying, like, look, there are guiding principles of nature that I think we've traded off with advancements in technology, and we can look at those and examine it. Probably all know what they are. I know I am so addicted to my phone. I mean, it's even if I go in to like have a bowel movement, I was like, I don't want to go with my phone. What am I going to do? It's just like, It's wild, the pull that it has on my psyche. So that is, in this nervous system that is calling out functionality to my organs. I can't imagine how that's not impacted. So long-winded answer to say there's so much that we can address with that. Like, what is that rhythm? What's the tone of my nervous system? I'm ever allowing a state of ease during the day because we're doing more. There's more information. There's more access to just, we have supercomputers in our pockets.
We do. Yeah, there's pluses to it and certainly some minuses as well.
Yeah, 100%. 100%. So I'm going to do an EpiSeq test.
Great.
And we're going to have another person from your team on, hopefully back in the future.
Okay.
we're gonna keep this ball rolling. I have, I feel like this is a good bird's eye overview of what we can do. Oh, this is the other thing I wanted to ask you before we go off this topic. With this technology, are there certain cancers that are more probable of being detected than others? Are there things that really like this type of technology would knock it out of the park on, and maybe some that it's not so good at yet?
Yeah, definitely. So great question there. There are strengths and weaknesses to the test just based on the biology of the cancers. So we talked about cell-free DNA coming out of the tumor. It looks like some types of cancer don't release as much cell-free DNA. We have a difficult time detecting those. And so the two ones where multiple, different people have trouble detecting them would be prostate cancer. It is difficult in a blood sample to pick that one up with the DNA-based method. And then breast cancer can also be very difficult to detect. There isn't a lot of cell turnover, just again, something about the biology there. We do have some information. I'm not sure if it's in our current publications, but we will have one coming out soon that kind of breaks down cancer by cancer, how we think the performance is, because that's really important information, especially if you're looking at a specific type of cancer you're worried about, to know that information. So we're trying to get that out there.
Yeah, I know, because there's on the website on precision dash epigenomics.com, there's like a scroller and it's like stomach, bladder, kidney. It's like showing me the organ systems, because I think there's 24 types of different cancers that could come up as abnormal pathway on the test. Is that correct?
Yeah, it could be more than that as well. So when we were
Okay.
designing the test, our goal is to detect cancer, right? And not really a specific cancer. So we looked for a signature that isn't specific to one cancer or another, but is kind of specific to cancer as a disease process. So the things on the website are likely cancers that we have detected with the test. So we've kind of shown, we've got evidence, we've got the papers to show we've detected this cancer. Now, there are a lot of cancers out there, right? And getting samples, doing these studies, we're continuing to do that work, so we'll continue to update the things there. But the test isn't really limited to a specific set of cancers. Does that make sense, Freddie? Yeah.
Yes. Yep.
Yeah.
A couple more questions. Is there anybody that should not do this test?
We recommend against in people under 18. And then also it's possible in pregnancy as well that false positives could be there. We haven't had any yet in pregnant individuals, but pregnancy is its own epigenetic behemoth. A lot of placental expression and embryonal expression, right, of methylation patterns are shared with cancer. And so we suspect the test may not be as specific in that population. So those are the two where we just don't have the data to say, hey, the false positive rate, it could be higher here. Wait till that baby's delivered, and then we'll do the test then.
Yeah. And so if this is something I want to get, do I just go to the website and I order a test? Is this something my doctor orders?
Yeah, so it's not available to patients right now without a doctor's order. We really value that kind of follow-up with your doctor on those findings. We really don't want somebody to find out something, in isolation. That's a bad way to find out, some news where you don't have follow-up. So we do require a physician to order it. You can look online. There's an order form there. You could print that out and bring it with you to your doctor and say, hey, I'm interested in this testing. That's a reasonable thing to do. Any good doctor would be fine with that kind of approach. Yeah.
Great. Yeah, that sounds really clear. Amazing. I thank you for your time. I'm super excited about this. I feel like I feel a much better level of education speaking with my friends about it when they're asking me about, because I just got, before we popped on yesterday, someone's like, do you do the circulating liquid biopsy? I was like, not yet. I was like,
Yeah.
I haven't done it yet. I don't know enough. I don't know enough, but this has been really, really clear. I think this is going to be incredibly valuable for people to hear. And then interesting, you said possibly the two that may not perform well, like breast cancer and prostate cancer. We have great screens for those already.
Yeah, absolutely. And
Amazing.
it doesn't mean that it wouldn't pick it up. It just means, again, that sensitivity, right? Our ability to pick it up early may be limited.
Yeah.
Absolutely.
Yeah. What I'm hearing you say is this is not, it's a great test. It's not a pass for you to go live like an ass. Like you still have to like do all the things, and you still have to follow up with your primary care annually like you normally would, and listen to your body.
Yeah. And it's not a replacement for the other screening tests that are out there. Those are kind of directly testing the tissues themselves, right? This is an add-on in addition to those things. So that's another point. You don't want to do this instead of a colonoscopy, for example.
Yeah. Well, it's, again, it's near and dear to my heart. I just had a family member go in for their first mammogram, no symptoms, and breast cancer, some levels of metastases. There was no signs, right? And so I just think, in the world that we live in, there's lots of change. Again, we mentioned this swing away from the guiding principles of nature. I think for me, it's a smart investment. I'm definitely going to do one. We'll definitely do a follow-up episode so we can get into the details. We can look at a printout, but I think this is a great starter. The Beautifully Broken podcast, Dr. Routh, we might title it Dr. Routh just so we get more traction. I joked about that, but now I think it's a good idea. Dr. Routh Talks Cancer. Is in this world of being beautifully broken, and this idea of when we fall and we put things back together, that's an opportunity for healing. What does it mean to you to be beautifully broken?
What a great question. I mean, to me, it's maybe about accepting that, this is a broken world, that we are broken and we can still do great things. We still have value, and things can still have value.
Yeah. And then if you had a magic wand, I'll let you have the magic wand again. You can tune in all the we'll do cell phones, not the TVs, cell phones of the world. They get to tune in to Dr. Josh. What would do you have in the state of the world right now? There's a lot of turmoil going on, a lot of polarity. What would you say to people right now?
I don't feel remotely qualified to be saying anything, especially this week, Freddie. Hang in there, I guess. We're going to be okay. Yeah.
We're going to be okay.
We're going to be okay.
I say the waves keep coming. They're going to keep coming. Yeah. Great. All right. Big love. I'll talk to you soon.
Thank you, Freddie.